Okay, hello and good evening. Assalamu alaikum. How's everyone doing? I hope everyone is doing good. I can see so many familiar names and faces. Dr. Bushra, Dr. Farheen, Iman, one iPhone, Saud, Manikam. Hi Manikam, how are you? Rabia, Saira, and one Samsung as well. And Fiza. How's everyone doing? Hi, Farheen. I hope
Fine,
everyone
ma'am.
is doing good. Hi Manikam, how are you? Good to have you
I'm
back.
fine, ma'am. Yeah.
Good. So, how are you doing after MRCOG? How is it feeling? Hmm?
I'm good, ma'am. Thank you, ma'am.
Very good, very
Thank you
good.
for the help you
Yes.
have done.
No, very good. And you are one of a dedicated candidate, I must say. Very good. Hats off to you.
Thank you.
Brilliant. Okay, so before I go on and start talking about these talks, which I believe is very important in terms of theoretical as well as our clinical practice as well, because we do see a couple of cases of HMB in adolescents, HMB in every age group, in fact, right, till menopause, and then comes the premature ovarian insufficiency. So we do have, the so many, the patients around suffering with this. So the actual dilemma, what the patients and the clinicians face is that how are we going to treat all these patients, isn't it? So I truly believe that these virtually new talk articles are, I mean, very impressive in terms of that they are covering A to Z of both these topics. So while I was reading all these new talk articles, because the HMB in adolescents is April 2024, and this premature ovarian insufficiency is July 2024. Okay, so while I was reading them, for myself, so I thought, why not? Let's have a talk, let's have a discussion on that. So I did plan the session. And apart from that, we are having our upcoming, the talk workshops as well. So I think this will give a fair idea to all candidates that how we are going to conduct that talk workshops as well before this January 2025 MRCOG2 exam. Okay, so let's start our session. So we are going to start with the premature ovarian insufficiency first, and then we are going to discuss this HMB in adolescents, right? So premature ovarian insufficiency. Who is going to define what exactly the premature ovarian insufficiency is? Anyone? Mhm. Any of you know the definition of POI? Or earlier we also used to say the premature
Cessation
ovarian
of menstrual
failure.
cycle before 6 years.
Cessation of menstrual cycle before
40 years of age.
40 years of age. Okay. All right. All right. And any laboratory diagnosis, sweetheart? Do you know? How do you diagnose? Any idea? Clinically, how do we
Diagnosis is
diagnose?
based upon follicle.
Mm-hmm.
Clinically, we ask the patient about the perimenopausal symptoms
Mm-hmm.
like heart flushing, sweating,
Laboratory
irritability, bone pain,
diagnosis. Laboratory.
and on laboratory diagnosis, we diagnose it by follicle stimulating hormone. If it is greater than 40 on international treatment per liter on 2 3 months 6 months apart.
4 weeks, 4 to 6 weeks apart. The samples, 4 to 6 weeks apart. All right. Yes. Now the cutoff has been decreased. Very good, Adila. It's not oligo. Oligo is a very different terminology. Okay. So never get confused with this oligo. Okay. Oligo is something else, and cessation or amenorrhea is something else. Okay. But still, we will check. So let's start that. First of all, we need to define that what exactly is it. Okay. So as Aisha said that the premature ovarian insufficiency is a clinical syndrome defined by loss of ovarian function before 40 years of age, right? So that makes sense. So first thing first, whenever you start any topic, so try to go about first of all its definition. I mean, what exactly are we studying, and then how are we going to approach towards that topic, and what are going to be the clinical signs and symptoms, right? So while we are talking about insufficiency will involve what? Ovarian follicular depletion, leading to estrogen deficiency and reproductive consequences. And it is characterized by menstrual disturbance, oligoamenorrhea, high gonadotropins, and low estradiol. However, at one point, the talk says the same, that if we are going to say the oligo, then we need to be very careful because, we are talking about insufficiency, and then we do have a failure as well. Okay, so when we will, talk about both, then the terminologies are going to be bit different. However, they are interchangeable. They are what you can say that, the fairly replaceable with one another. Okay, so what will happen is that follicular depletion, ovaries are not working. So what will happen is that the hormones which are coming from all the way from brain, they are going to be high. And the estrogens which are produced by the ovary, by the follicles, they are going to be depleted. The etiology is diverse, right? Etiology is diverse and it includes genetic, autoimmune, iatrogenic, and environmental factor. So the age cutoff of 40 years of POI is set by the clinical observations, with it being 2 standard deviations below the average age of the natural menopause, which is 52, 54 years. Then, how does it represents? It may represent as primary or it may present as a secondary amenorrhea. However, because the residual function of the ovarian follicles, about half of those with the POI experience oligomenorrhea due to intermittent ovarian activity. But what will happen is that because we do have governing bodies, right? Who give us guidelines? While we are in our MRCOG curriculum, so yes, we are going to be following either ASHRAE guideline or either British Menopause Society for this. So British Menopause Society and ASHRAE define oligoamenorrhea as the absence of period for at least 4 months, while BMS suggests a follicular FSH of more than 40 on 2 tests 6 weeks apart for initial diagnosis. However, the NICE says more than 30 on test 4 to 6 weeks apart, right? So all of us have been studying this NICE menopause guideline, right? Menopause and HRT, isn't it? So many of us know only this definition, that we have to go for more than 30 international per unit per liter on test 4 to 6 weeks apart. However, ASHRAE, now European Society of the Reproduction, it says a lower threshold of more than 25 on 2 occasions more than 4 weeks apart for POI diagnosis to ensure inclusion of women with autoimmune POI who have lower range of FSH levels. That makes sense as well, isn't it? So we are going to take this now because this is relatively the new definition. Okay, but remember this NICE definition as well. These two are very important for us, for all exam going candidates. So now another exam percentage is going to be, what is the prevalence? How does it affect the population? It affects almost 1% of the women under 40, with decreasing prevalence in younger age group, 0.1% under 30 and 0.01, even more less in 20. So write it down in your notes if you guys are making any, okay, because this is a very important percentage. And then this is another percentage, important one. The spontaneous pregnancy can occur in up to 5 to 10% of women. Very simple and fairly, you can memorize it so easily. Then comes why POI occurs. Because we are talking about ovaries, okay? Ovaries function is declining. We all know that ovary has got follicles. And once the girl, the child is in the womb, so what will happen is that, the ovary will start making number of follicles. So primordial follicles are going to start from 4th fetal month, reducing to 1 million at birth as the follicles continually undergo apoptosis or atresia. By the time a girl reaches the puberty, what will happen is this number will drop to around 400,000. So what will happen is a woman will ovulate only about 400 oocytes in their reproductive life. That makes sense. And the reproductive life is for about 52, on average 52 to 54 years. Or you can, on average, you can say the 51 to 52 years. The follicle number decreases by 25 to 150 per day until the menopause. So now we call it as ovarian aging. Ovarian aging means that the number of the follicles are being released from the ovary. Okay, so because naturally we have said that the natural, the decline of the menopause is going to be towards, when a woman approaches the perimenopausal age group. That we call it as ovarian aging. Then the best fertility period is going to be when a woman is between 20s and 30s, right? So what will happen is that ovarian aging characterized by a decline in the follicle number and its quality is pronounced by the mid-30s, culminating in menopause in the early 50s. Menopause time depends on two key factors. When do we say that a woman has had menopause? Number one, peak follicle count and the rate of the follicular atresia, of course. Then women or girls with a small follicle pool at birth or experiencing an accelerated depletion of the follicles through apoptosis will develop POI. Okay, when we talk about, this decline in the or depletion of the follicles, which do you think is the clinical or the iatrogenic cause most of the time? Any example clinically? Although it is not documented, but yes, it is the cause. Ovulation induction. Okay, when there is multiple follicular ovulation induction, what will happen is that, if an ovary has to release one follicle, okay, then with the help of ovulation induction drugs, what will happen is that one ovary will release almost 10 to 20 follicles per month, per cycle. So what will happen is that the number of follicles inside the ovary are going to be reduced. That can also be the iatrogenic cause of premature ovarian insufficiency in many women. Okay? Okay. Then, if we talk about premature ovarian insufficiency, the first and the foremost important cause is going to be the genetic. 20-25%. Write it down. If we are talking about genetic factors, then there are going to be multiple genetic factors. FMR1 gene mutation, okay? It is going to be with POI, but it is not going to be associated with intellectual disability because POI women are going to be normal, okay? So apart from chromosomal aberrants, other gene mutations linked to POI are going to be affecting the folliculogenesis like FOXL2, no-box gene, as well as those involved in the DNA repair like ATM, ataxia telangiectasia mutation, galactosemia, autosomal recessive disorders, which may also elevate the POI risk due to the secondary hypoglycosylation at the cellular level. Women with blepharophimosis, ptosis, epicanthus inversus syndrome, okay, BPES, are also at high risk of having POI because they also have FOXL2 gene, the mutation. So these days, what this talk is talking about, that recent studies in the genomic technology, such as whole exome sequence, are likely to uncover more genetic causes in the near future. So that is also a conclusion in this POI chapter as well. Then comes autoimmune. We all know that, autoimmune is a cause, right? So if we are talking about, the one autoimmune disease factor, so it means then we have to talk about other, the autoimmune diseases in the body as well. Like I always teach to my student that one autoimmune condition is not going to be, with, the another autoimmune condition. For example, very, very common autoimmune condition do we see in our patients is diabetes. And many a times we do see hypo or hyperthyroidism in those patients as well. Now, if you will observe in your clinical practice or in your hospital, you will, observe this thing as well. That many a times, if a woman is diabetes, either type 1, type 2, they are going to be having, thyroid or any other, the autoimmune disorders as well. Okay, so whenever we think any autoimmune cause for any disease whatsoever, always, always, and always look for secondary or any other brother, sister autoimmune disease in the body. Okay, because it can coexist. So POI can also coexist with other autoimmune disorders such as Edison disease, thyroid illness, and then they do have squamous cell carcinoma antibodies in 4 to 5% of the cases. Adrenocortical antibodies, particularly 21-hydroxylase, adrenal gland, it is also associated. Then what will happen is that, of course, if you are suspecting anything, then you are going to identify, the women who are having, the kindly mute yourself, everyone, please, because it really causes a lot of disturbance. Okay. So POI is often seen in cases of thyroid autoimmunity as well in 14 to 27%. Okay, so I think for exam, the perspective, all these are important points. So note it down, whoever is going for exam. Then iatrogenic, yeah, iatrogenic means which are caused by anything which is not related to the body. However, it is going to damage the ovary. For example, chemotherapy, radiotherapy, right? And what will happen is that it will cause tissue damage and decreased ovarian reserve. Surgical intervention, for example, oophorectomy, of course, it is going to be the iatrogenic cause or surgical menopause. We call it as, if we remove ovaries and, the uterus as well, we call it as surgical menopause, isn't it? So what will happen is that, it will, any condition which is going to touch the ovary. So of course, it is going to, number one, damage the ovarian stroma, follicles and everything. So even if the ovaries are there, so what will happen is there is going to be declining of the, the follicles or the ovarian function. Right? So what will happen is that some of the time, what will happen is that AMH level is going to be decreased. Anti-Mullerian hormone is going to be, the decreased. Why? Because if ovary has, the follicles, so AMH is going to be released from pre-antral follicles. I'm sure you guys know from the physiology of the menstruation that, when the pre-antral stage is there, then the antrum and the antral cavity will, the form. So what will happen is that pre-antral follicle will secrete AMH. So AMH level will tell us about the ovarian reserve. Ovarian reserve mean that what is the potential of ovary, to release the, the ovum, then, they convert into the fertilization and then pregnancy. Okay, so this is very much important. So while surgery for bilateral ovarian endometriomas may result in POI, unilateral surgery does not exhibit the same association, of course, because if one ovary has been removed, the other ovary is there. So yeah, woman fertility is preserved. Then infective cause, any infective such as, the virus like HIV, herpes, CMV, TB, malaria, varicella, shigella, they have causal relationship, but it's not, you can say that it is very much established. But yes, it can be. Idiopathic. Idiopathic can be related to the environmental influences such as lifestyle choices, unexplained genetic variants, and such cases may involve a rapid decline in ovarian follicles or reduced gonadotropin responsiveness. Word is responsiveness. Means if a woman is coming to us with the the complaint of subfertility, and if we want to give her gonadotropin as a ovulation induction agent, so what will happen is that in idiopathic POI, those gonadotropin will not work properly. Okay. Then, environmental, any toxin exposures, anything which is going to, anything which is going to affect ovary. So of course, what will happen is that ovarian stroma, ovarian follicles will be disturbed or damaged. So hence, a woman will be at verge of development of POI. So life characteristics such as early menarche age and nulliparity have also been linked to the POI. Clear, everyone? Any questions so far? I think it is pretty, the easy. Any question? Everyone is so quiet. It means everybody has read this dog article, yeah? All right. Okay, so how do you diagnose? Yeah, very important. Diagnostic workup is very much important. So it has got 2 steps. Okay, 2 steps means number one, first of all, you have to confirm the diagnosis and then you have to establish the cause. 2 beautiful things, isn't it? First of all, you need to label somebody with POI, and that is a very big thing because it will come under the breaking bad news. If you have to tell it to somebody that you have developed this, the premature ovarian insufficiency. So what is the reason? So generally speaking, inshallah, after part 2, you will go for your part 3. So this will come under the heading of breaking bad news. It means you are labeling somebody with POI, right? So first of all, you have to be 100% sure of that this woman has developed POI, and then you have to establish the cause, and then you have to manage the case, isn't it? So the Escherichia criteria for diagnosing under the age of 40 are a combination of oligomenorrhea or amenorrhea for at least 4 months and two measurements of high FSH level of more than 25 taken at least 4 weeks apart. Then when Aisha said and Adila, the both, a thorough medical history and physical examination is needed, family history is needed because you have to identify either genetic or familial patterns, right? In teenagers with suspected POI, assessing secondary sexual development is critical, as delayed or halted puberty may suggest POI. Okay, that makes sense, isn't it? If puberty is delayed, this is also a very good topic. So maybe, someday I will conduct a separate session on that, the amenorrhea, that is very important because it is not given anywhere in the syllabus. So halted puberty, it may suggest POI. So what you will do? You will have your FSH level because we are talking about ovaries, right? So ovary has got, the receptors for estrogen and progesterone. I'm sure everybody is aware of uterine cycle and ovarian cycle, right? So ovarian cycle has got, the phases. So in that scenario, the first half is going to be sensitive to the FSH, okay, then LH, and then, the other. So what is happening? Level of estradiol, LH, AMH, among other hormones might provide additional indications of diminished functional ovarian reserve. So estradiol levels are often low or in the lower limit of the normal range in the POI, while LH levels may be elevated. AMH, however, on the other hand, a direct measure of the residual ovarian follicle pool, is often very low or undetectable, of course. So usually, if we are, because many a times, how do we diagnose? We are going to be diagnosing this when a woman is coming with the either clinical sign and symptoms of, the POI, okay? Or if a woman is coming with the secondary or primary subfertility, right? So in that scenario, of course, we will extend our workup and then only we will come to the conclusion. So chromosomal analysis is recommended in all non-iatrogenic, regardless of the age. Autosomal genetic testing is reserved for only for specific cases. Okay, pelvic scan only to exclude uterine causes of secondary amenorrhea such as Asherman syndrome. Ultrasound assessment of ovarian follicles may be helpful, although its utility is diagnosing POI is limited, of course. Because if we will talk about ovarian follicles in terms of scan, that is going to be important when we are going to put somebody on ovarian induction, ovulation induction, and then we are going to measure the size. Okay, so in POI, it has got a limited, you can say the value. So never offer ultrasound to diagnose POI because it's not going to give you any clue. Autoimmune profile, if you have any potential cause of the POI despite lack of the available specific treatment. For example, if we are suspecting this POI, then yes, that thyroid, the antibodies, then, the diabetes, then adrenal, the diseases might be helpful in telling us something. Once POI is diagnosed, baseline general health assessment is crucial. Then, of course, we are talking about estrogen. Yeah. So estrogen is important for every woman there is, isn't it? From head to toe health, starting from heart, bone, yeah. Then comes, the muscle mass, then comes, the sexual health, right? Then comes urinary tract, everything. So what you will do? Of course, in that scenario, we are going to do the bone health assessment of the dual, this DEXA scan at the time of diagnosis and later on regular basis because woman is going to be at risk of osteoporosis. Cardiovascular health, the issues. Hypoestrogenemia elevates the cardiovascular risk. Regular monitoring of lipid profile, blood pressure, along with lifestyle modification. Psychological assessment. Psychological assessment. Psychological issues, apart from this POI, they are at raise in our, the community and even the worldwide, right? So if any woman who is suffering with POI, estrogen deficiency, and having any background risk of any psychological issue, mental health problem, so that woman is at verge of development of, a pronounced psychological or mental health problem. So very important that, we are diagnosing properly and then we are managing it properly as well. Okay. So considering POI's impact on fertility and long-term health, often leading to an anxiety, depression, and emotional distress as well. And this we do see quite often in our, the clinics as well, that women do come. And because nobody gives any attention, proper attention to mental health issue, so, but, this is very crucial. So start thinking, out of the box. So whatever you study for yourself, for your exams, always think that how this study can be useful for my patients. How can I be a better consultant or a better doctor to my patients as well? Okay. So when I was reading this talk article, I literally found this talk article very helpful, although I knew, the many things, but yes, always, it always helps. All right. So I hope you guys will be, just one moment. People are here to join. Okay. So I hope things are clear now. That first you will diagnose, and then you will establish the cause, and then you will come to the management. Okay. So now let's quickly review. Okay. So what is happening? Oligo or amenorrhea, but I think it is basically amenorrhea. So let's not get confused with the oligo, because nobody knows the exact definition of oligo. This is my, the understanding for this POI after reading so many things. So better to say amenorrhea for at least 4 months, first of all, and plus FSH level of more than 25 on 2 occasions for more than 4 weeks apart. You will make a diagnosis, and then you will go establish the cause. You might offer antibodies in case of POI of unknown cause or of an immune disorder. If it is positive for ACA and adrenocortical or 21 hydroxylase, deficiency, you will refer to endocrinologist. See, this part is establishing the diagnosis, okay? And this part is diagnosis. So how you are going to do? Yes, diagnosis of, if it is genetic karyotyping you have done, if it is Turner syndrome, you will refer to endocrinologist, cardiologist, and geneticist. This is another topic, Turner syndrome, right? If it is because of the presence of Y chromosomal material, you will discuss gonadectomy with the potential. And what is this condition? If we are talking about gonadectomy with the patient, Y chromosomal material.
Ma'am, Turner's mosaic, ma'am.
No, sweetheart. Turner mosaic is going to fall in this. But if we are talking about gonadectomy, then it is AIS. Okay? Androgen insensitivity syndrome. Because in that scenario, the woman is not going to be having, the proper this. So AIS is going to be that. Woman phenotypically is female, but genotypically is male. Because the karyotyping is going to be 46XY. Okay? You got my point, Manikam. So 46XY, it means the gonads are there, testes are there. That's why you have to remove those gonads, because then those gonads will convert into carcinoma later on. Okay. So once the girl approaches to puberty, we will be talking about, the gonadectomy, because those, the gonads are going to be in the inguinal canal only. So we have to remove them. Okay. All right. Then if in terms of genetic, then Fragile X syndrome. If Fragile X syndrome is there, then we will refer to geneticist, and then see, diagnose and establish the cause, and then manage. So if we are talking about any thyroid peroxidase antibodies, so of course, we will offer them test for TSH every year, and we will refer to endocrinologist as well. Plus, of course, if we will find out any other cause, any autoimmune antibodies, so we will have essential workup after the diagnosis of POI, or maybe additional workup as well. Then comes the implications. So what will happen with the estrogen deficiency? We have just spoken. So the care needs to be comprehensive yet individualized, comprising hormonal therapy, lifestyle changing, fertility management, and psychological. Psychological support is a prime, the factor in the management of POI. It is critical that women with POI receive information about their diagnosis and treatment options, and that they participate in decision making as well. General advice on health, including lifestyle modification, maintaining bone health, should be given. It should be informed that the potential increased risk of cardiovascular diseases, and counsel to follow healthy lifestyle habits that can help decrease this risk. Plus, the healthy balanced diet, adequate intake of vitamin D, calcium, regular exercise, smoking cessation, avoidance of excessive alcohol, regular blood pressure and lipid profile monitoring as well. It's very important. Then comes another important aspect, HRT, right? So anybody has any idea about HRT? What are the different types? What are the different routes? How do we prescribe and how do we, monitor? Any idea? Anyone? Why do we give HRT to any menopausal woman? Okay. Let me rephrase the question.
To alleviate perimenopausal symptoms.
To alleviate postmenopausal symptoms, to alleviate the estrogen deficiency. Yes. Very good. Oral, transdermal, combined. Okay. Okay. Let's simplify. If we just talk about the HRT. So HRT is going to be of two types, right? Either it is going to be the sequential type or either it is going to be, the continuous combined. In terms of menopause, sequential means it is going to be sequence-wise. It is going to be mimicking the ovarian cycle in the premenopausal age group. Okay? So what will happen is that in that scenario, in sequential, towards menopause, I'm talking about, not POI. If woman has any irregular cycle close to the menopause, so what will happen is we will offer them this sequential because their cycle will be regular and they will be having some relief from the menopausal symptoms. But continuous combined or say CCT, right, that is going to make a woman, completely, the amenorrheic. So women will not have any regular bleed. Okay. Then comes combination for HRT because we have to mimic the normal ovarian cycle. So we do need estrogen, we do need progesterone as well. However, because earlier we have spoken about what? Decline in the ovarian function, ovarian aging. So with the passage of time, what happens is, with the decline in the ovarian function, there is going to be decline in the production of the estrogen as well. Right? So that's why towards, the natural age of menopause, after 40 or say 45, women will be having an ovulatory cycle. Means they are going to be having cycle, but those are going to be anovulatory because of the ovarian aging. Okay? So because, of course, if estrogen is not there, so what will happen? The woman will have, the problems head to toe, So what do we need to do is that we have to give them HRT to alleviate all those symptoms that will mimic the natural hormones from the body, estrogen and progesterone. However, when we will give them from outside, those are going to be synthetic, isn't it? So those are going to be either estrogen and progestogens, not progesterone. Okay. So progestogens are going to be the synthetic form of the progesterone, right? So when are you going to initiate? Very important. Okay. So first of all, counseling is important. First of all, talking to the woman is important because, you have to tell them that why are you giving them HRT? What is the role? What is the benefit? So HRT is going to be on the basis of the treatment for women with POI. And what is your aim? To achieve physiological levels of estradiol. Because we have lost estrogen because of the POI. So we have to give estrogen from outside. Right? So initiating HRT early may hold particular significance for young women diagnosed with POI as it optimizes the attainment of peak bone mass and mitigates the cardiovascular risk factors. What we are afraid of in menopause age group, right? We are afraid of, the cardiovascular risk factors and osteoporosis. So if we have to give anything to POI women, so it means that we have to protect them from all these, the debilitating problems. To mitigate the enduring health ramifications resulting from ovarian function loss, ESHRE recommends continuation of the HRT until the age of the natural menopause, which is 50 to 51 years, unless there is any contraindications. It means, for example, if a woman has developed POI at the age of 35, so it means she has to continue it until at the age of 51 at least. And they will have regular review, yearly or maybe 5-yearly. If everything is going fine, so she can be kept on the same HRT, right? So what will happen with HRT? We are giving them estrogen, we are giving them progesterone. So what is happening? They will be having improvements in the vasomotor symptoms, sleep problems, mood, sexual function, and general quality, and their life will be good. And it is imperative for the women who do not want to become pregnant. Okay, so we have to give them reliable contraception as well. So another take-home message should be that HRT is not a contraception. Okay, this is also another good thing, because the dose, because of the what? Because of the formulation, because of the strength of the estrogen, and because of the the type of the estrogen as well. Because it may contain estrogen and progesterone, but the quantity and the type of the estrogen progesterone is relatively different from the contraception. Okay, so HRTs are not contraceptive. This is the one good point to remember. So what are the types? Estrogen, progesterone, it can be taken orally, transdermally, or it can be the mixed. The progesterone component of HRT, it can be having the local 1 Mirena. The HRT regime, dose, mode should be tailored to the woman's symptoms, health status, personal preferences, and the risk of the side effects. During HRT, women should be continually followed up to check response. Very important. Initially, you have to have a good follow-up for weekly, right? So it is very much important that, the treatment should be adjusted, and you have to screen for any adverse effects as well. So it means our aim is what? To mimic the natural estrogen level. Okay, so HRT for women with POI aims to mimic the natural estrogen level. So available estrogen types are 17 beta estradiol, which is more natural of the ovarian origin, ethinyl estradiol, which is synthetic, and conjugated equine estrogen, CEE, which is derived from pregnant mare urine. Okay, mare is the female horse. Okay, so this is derived from the female horse urine, this conjugated equine estrogen. This is going to be, I think, an exam question. Now, CEE is rarely used nowadays because of increased risk of hypertension and thrombosis compared with the conventional HRT with 17 beta estradiol. Because when I was studying for myself, my exams, so we always used to talk about only, conjugated equine estrogen, equine estrogen. But now see, now they say that they are not, the favorable or rarely used these days because they have got risk of hypertension and VTE. Write it down. So I think this can be a potential exam question as well. Okay. So the CUCP with ethinyl estradiol is an option for estrogen replacement for those requiring, the contraception, considering a small risk of conception in women with POI. And what was the risk of spontaneous conception? 5 to 10%. And nobody knows when that conception will occur. Okay. And when it is going to occur. Nobody knows. After maybe, after establishment of the diagnosis of the POI, maybe after a few years, maybe after a few months, or maybe no. Okay. So CUCP is preferred by some women because of its familiarity. Very important. Everybody is familiar with CHC, right? Because it provides the excessive hormones that needed for the physiological replacement. Note it down. Excessive hormones, right? Like I earlier said, that the formulation is a bit different, right? Dosages are different as well. And with less favorable effects on the lipid profile and thrombotic factors with increasing the thromboembolic risk. If better compliance with contraception can be assured with the preferred option of COCP, then you will give a low dose pill, 20 microgram, right? Usually the conventional CHC, what do we give in our patients is, and it contains 35 microgram estradiol, right? So, but if we have to, give them to these women, we may prefer this 20 microgram. And it is best to run through packets with fewer breaks of 1 week every 3 to 6 months. See, important. It means that every 3 to 6 months, patients will have a break, but she will have a regular, the hormones. So after 3 months, they can have, the break, and then, they can start again. Or no breaks at all. Depends. Because we are talking about premature, So in these, we have to mimic almost normal cycle. So we can give them, the continuous. After 3 months, we can have a break, and then we can start again. So what will happen is that we are going to avoid frequent estrogen-free intervals of the, the conventional regimens with a pill-free week every month. So we will give them pill-free week, but every 3 to 6 months. Then comes progesterone. So HRT regimens with 17 beta estradiol are more beneficial for bone mineralization and cardiovascular health than COCP. Good concept. Such treatments have been shown to increase the lumbar spine BMD and positively affect bone formation markers and cardiovascular health. For women with the uterus, progesterone supplementation is important because what will happen is that continuous estrogen will do what? It will increase the endometrial thickness, right? It will increase the endometrial thickness. So in the premenopausal age group, we need to shed this endometrium. If this endometrium will stay in the uterus, what will happen is the chances of development of endometrial hyperplasia and eventually endometrial carcinoma later on. So that's why withdrawal is very important. So progesterone is for withdrawal of bleeding. So what is happening now? We are preventing, endometrial hyperplasia and the reduction of the cancer. Progesterone serves a protective role by mitigating the mitogenic impact of the estrogen on the endometrium, of course. So synthetic progestogens provide effective cycle control and endometrial protection. However, body identical means micronized natural progesterone may have a more favorable cardiovascular safety profile than the synthetic progesterone. Okay, and what is the name of the micronized progesterone? Anyone? Any idea? Anyone?
You are asking about trade name?
Micronized progesterone. No, not trade name. Do you know what is the, the progesterone? Cyclogest. Okay. So what is the content of cyclogest? Let me rephrase the question again. Why do we prefer this micronized progesterone? Because it will have less progesterogenic side effects. And what are those progesterogenic side effects? Headache, bloating, weight gain. Okay. Or patient may have the sign and symptoms of depression and anxiety as well, right? So if we are using micronized progesterone, so what is happening? That we are reducing all these side effects, mostly cardiovascular, the side effects. Dihydrogesterone, okay? Dihydrogesterone is going to be there. So that is very important. Remember that. All right? Zonera. Okay. So we do have, the therapies. So estrogen, when it will comes to the estrogen, so it's going to be micronized 17 beta estradiol. What is the formulation? What formulation is oral. All right. If it is transdermal, then the patches are there. If it is conjugated equine estrogen oral, then it's going to be 0.625 to 1.25. Okay, CEE. Generally speaking, those, the tablets traditionally were going to be there, I think, but now these are withdrawn, like Premarin, right? If you guys have ever heard of that, okay, Premarin oral tablet and Premarin vaginal cream as well, local. Okay, so that was 0.625 milligram, right? Okay, so when do we talk about progesterone? We do have continuous progesterone and we do have sequential, right? If it is continuous, then medroxyprogesterone acetate, MPA, and the strength is 2.5 to 5 milligram, and it is oral formulation. If it is, the micronized one, oral, then it is 100 milligram. If we talk about sequential, then see the dose is more because we have to stop the periods there and then. Okay, so it is going to be in sequential because it is going to be in sequence. Estrogen first and then progesterone. Okay, it will mimic the natural cycle. All right, and here the dose is less, but it will make the endometrium thin later on. So in the first half, we are giving estrogen. In the second half, we are adding the medroxyprogesterone acetate, 12 days each month. Or either we are giving micronized progesterone 200 milligram daily oral for 12 days each month. Okay, so this is how the formulations are going to be in the POI. If we talk about the fertility, of course, it needs help conceiving. And most of the time, women may need to go for IVF with donor oocyte. Okay, so if at all a woman is coming with POI and if she is coming with the complaint of subfertility as well, so what you will do? You will start your workup, isn't it? After history examination and thorough investigation, you will start your workup and then you will come to a conclusion. And for the IVF, the marker which we are going to be using for, the ovarian reserve is AMH. Always remember, AMH is not for the diagnosis of POI or menopause. Okay, AMH is the marker of fertility, ovarian reserve. All right, so never choose AMH. Okay, so women should be educated about the risk of treatment failure, potential problem, obstetrical complications, psychological, ethical, and legal aspects of using donor oocytes, because it will, they vary from country to country and religion to religion, right? So pregnancy after oocyte donation is considered high risk, and a woman should therefore receive hospital-based antenatal care. Given the significant psychological burden associated with the diagnosis of POI, referral to the psychologist or psychiatrist of ongoing support and cognitive behavioral therapy may be beneficial. So it is a very different, the topic, that how do we manage the fertility in the setting of POI, because I think we do have two talks on this. Okay, talk on MRKH and talk on Turner syndrome. Okay, and there is another talk as well, the management of the ART or the fertility potential of in the woman with the ART. Okay, so many things are going to be there. So other prevention and supportive care. So far, is it clear, everyone? Everything is clear, guys? Any questions so far? Any yes, any no? Or
Yes, ma'am. Clear, ma'am.
lethal silence? Okay. Hi, Suparna. How are you? Okay. Brilliant. Okay. Good. So make your life easy always. Okay. Define, then establish the diagnosis, then manage. Okay. And then comes, the step by step. So if you are managing the symptoms, you will be talking about HRT. If you are managing another, the important aspect of POI, which is subfertility, then it is going to be a separate topic. But yes, you need to understand at least the basic one. Always remember, at MRCOG level, be it MRCOG 2 or 3, nobody is expecting, any specialist. Okay, you are still a student. Doesn't matter if you are working as an independent consultant in your own, the countries. All right. So think yourself as a student while you are solving any question. There should not be any aggressive management or aggressive the treatment in the exam. Okay, nonetheless, if we are using it in our clinical practice, don't bring that into your exam. All right, so always think as the primary student or the primary candidate, that what a student will think about in this, because MRCOG goes step by step. Okay, first step, then second, and then and there should not be any aggressive approach towards treatment. All right, so how do you prevent or do you give any supportive care in terms of POI? So administration of the GnRH agonist during standard chemotherapy protocols has been shown to reduce the incidence of ovarian dysfunction and POI. It is important to assess and monitor compliance, satisfaction, potential side effects, and the need of adjustments as well. In cases where osteoporosis is diagnosed and treatments such as estrogen replacement or alternative therapies are started, it is advisable to conduct follow-up BMD assessment, okay, bone mineral density, and you are going to assess with DEXA scan, okay, every 3 to 5 years. Okay, then another important question. Low libido, because if estrogen is not there, women will be having psychosexual disorders. But if the complaint is directly low libido, despite giving her adequate estrogen replacement, you may add testosterone. Okay, so testosterone is going to be the first line treatment in terms of low libido, even in the premature ovarian insufficiency as well as in the menopause category. Okay, so testosterone can be administered via gels, and decisions regarding any androgen replacement means testosterone should consider women's replacement. While they are not licensed preparation available for women, we may use testosterone 40.5 milligrams sachet. It can be used over 8 days, such that women with a 5-gram dose daily. Or there is Androfem 1% cream in 50 ml tube, 0.5 ml per day, licensed in the Australia for female use, is imported to the UK for private use under special MHRA license, and it is well tolerated with less side effects. Okay, so to conclude this, for exam candidates, okay, testosterone supplement is not licensed yet, but off license we do have gels and we do have creams. All right, and they are under MHRA license. Prior to commencing any androgen replacement, so what you will do, it is advisable to establish baseline testosterone level and subsequently reassess these levels at regularly intervals with initial follow-up, and that should be every 3 to 6 months. Okay? Then management of POI in special situation. So HRT can be used for people who have BRCA1, BRCA2 gene mutation and who have had bilateral salpingo-oophorectomy but do not have a previous record of breast cancer. That is what Esri says. Esri says transdermal estrogen in postmenopausal women does not increase the risk of thrombosis unlike oral estrogen. I think we all know this, right? Transdermal HRT is for patients with hypertension, with PTE, with history of migraine, with aura. Exam question straight away. In cases of endometriosis, which necessitate oophorectomy, combined estrogen-progesterone therapy addresses vasomotor symptoms and reduces the disease reactivation risk. Okay, why? Because we all know that endometriosis is what? Presence of endometrial glands and stroma outside the uterus, right? So even if somebody has had TAHBSO, she still needs, the COCP for quite some time because we don't know where are the endometrial implants in the body, okay? Because those implants can be, they implanted in the pouch of Douglas, it can be, the over any intestine or, the here and there in any pouch, right? So anytime, the hormones will secrete, so those glands will bleed and patient may have pain later on as well. So in fact, after that, you have to put the patient on HRT or you have to put the patient on COCP as well, okay, to decrease the disease reactivation risk, all right? Then puberty induction in terms of Turner syndrome, that is another, the topic. In this, what do we do is usually in Turner syndrome or Turner mosaic, So again, patient will present with primary amenorrhea, okay? So we will have a complete, the thorough history. We will have complete, the Turner syndrome in our mind. And then we are going to diagnose, right? We will optimize general health, breast and uterine development. So first, what we will do is we will, give them induction therapy. First, we will give them, the estrogen, okay, to build the endometrial lining for quite some time. All right. So estrogen therapy is commenced at least more than or equal to 12 years of age who do not experience spontaneous onset of puberty or even progression of the breast development. Then it will be puberty. The process of puberty is characterized by gradual progression, and it is recommended that replacement therapy during the induction process should aim to replicate their natural tempo. So we will induct the girl with estrogen for about 2 to 4 years because the process is gradual. Okay, the process is slow. First, we will maintain the endometrial lining, and then we will introduce progesterone for the shedding of that lining. So we will maintain what? We will bring what? Normal, natural uterine and the ovarian cycle. Again, chances are very, the grim in these Turner mosaic or Turner syndrome women that they may conceive spontaneously. Okay, although with this, the estrogen and progesterone, they might develop their, the secondary sexual characters, the breast development, pubic hair growth, axillary hair growth as well, plus bone mass and, their height as well. But yes, for the, the uterine health, we need to supplement them with progesterone gradually. Okay, so 12 to 13 years, if no spontaneous development or a FSH elevated, start low dose estrogen. Then gradually increase estrogen dose, 6 to 12 months interval for 2 to 3 years to the adult dose. Then when they attain 14 to 16 years, the process may take 4 to 5 years. So it needs a lot of patience by the patients and by the clinicians as well. Okay, so what does it require? It requires a lot of positive communication. Okay, counseling, right? Counseling, when we talk about counseling, then I think, and I personally believe, psychosexual counseling has got the prime importance in these patients. So then you will begin cyclical progesterone after 2 years of estrogen or where breakthrough bleeding occurs. Then you will add progesterone, okay? What we have discussed earlier in terms of, the doses. Okay? So this was all about this, the POI. Any question, guys? Any question? At least say something, yes or no. Was it clear or was it not clear? All right. Very good, very good, very good. Okay. Brilliant, brilliant. Thank you, Fiza. Thank you so much. Thank you so much, Parna. Zunaira, very good. Farheen, good job, good job. Aisha, is it clear to you? Saira, Iman, Yegu, Saud.
Wonderful session. It was a wonderful session, and especially your melodious voice and a way of making us understand.
Thank you so much, sweetheart. Thank you so much. Okay, okay, brilliant. So this is for the candidates who are going for January 2025 exam. So I'll be conducting all these workshops, okay, 7 days each, because I think we do have a couple of interesting talk articles in terms of exam as well as clinical, because when I teach with all aspects, okay? Theoretical is, yes, important, but for me, I think it's a very good idea that you have to be a good doctor as well. That once you leave the class, at least you take the take home message as well. Okay. So once you will close your books, you will close your, the devices, at least you will think about that, what I have learned through this, the topic or session, and how am I going to be productive for my patients. Okay. Regardless of that, yes, we have to pass this exam. Okay. So what you need to be you need to be a good doctor to your community. All right. So yes, Adila, it will be available. Yes, Lubna. Yes, yes, stay safe, drive safely. All right. So what do we need to do is that we have to revise right before exam talks and right before exam EMQs. So I will be conducting an exclusive EMQ, only EMQ workshop, and also, the recall, the workshop as well. So any student who is interested can get in touch with me or, the Mehwish or my team members as well. Okay. So inshallah, we will be having, the good sessions. All right. And I am not, kind of that, you have to have a very large or huge group to teach. Okay. Because my motive is to whatever conduct to, the conduct peacefully and beautifully. So at least students will learn, and in turn, students will be a good doctor as well. Okay. Yes, Fiza. Yes, yes, yes. Very good. I'll be, waiting for you. All right. So let's just quickly have a 1 minute break or maybe few seconds break to start our next talk article. Okay. So just grab your water or juice or coffee or anything. Just 1 minute or maybe 5 minutes break, and then we will have the other session. Okay. Let's have a 5 minutes break. Okay. Okay, let's start. So our next topic is heavy menstrual bleeding in adolescents, who to investigate and how to manage it. A dilemma, isn't it? This is what we do face in our day-to-day practice. And, sometimes personally, me, myself, to feel very less confident when I deal with all these type of cases. So, I feel very, happy when I read this talk article because it really helps you a lot, because you have to study, you have to increase in your knowledge, as well as you have to bring that knowledge into your clinical application as well. So I hope this is going to help you guys as well. So let's get started. So this is for this, I have already spoken. And yes, the MRCPI theory. So the candidates who are going for this MRCPI as well, so I will encourage them. They can join me in, the very, what you can say that nominal fee. Okay. So fee is important, although, I do try to conduct as many as free sessions, but for, the ongoing long-term commitment, fee is important for you students, for me, the teacher as well, because you are going to be bound and I'll be bound as well that yes, we have to come for the session and we have to, the join our class as well. Okay. So anyone who needs any kind of help, because I'm freely available on WhatsApp, on, the Facebook, on Telegram. So do, to talk to me, do approach me inside the course, with the course or without course. Okay. Doesn't matter. So I will try to help. Okay. So the candidates who wants to go for MRCPI theory as well, so you guys are encouraged. And in fact, I will encourage to all candidates who are aiming for MRCOG2, because January exam is going to be there. Then you will have, the gap, because you cannot go for May OSCE right away, because, the OSCE needs a little bit preparation. So you will aim for November. So to bridge that gap, I think MRCPI is a good choice. Okay. So MRCPI is going to be in the March. So if you will, go for the March, so what will happen is that you will prepare for both OSCEs, because the both OSCEs will be conducted in the November. So I think this is a very good approach. Okay. So anybody who wants to go for, the both, so you guys can talk to me in person. Okay. So we will have, the good discussion and we will enroll you. All right. So let's talk about this HMB. How do we define HMB? Anyone? How do we define HMB? What is HMB? Hmm? Anyone? Any idea? Hmm? Okay, because there is no, the figurative definition, right? Because what is the, okay, let me ask another question, very basic one. What is the normal amount of menstrual loss? Bleeding, I mean, normal bleeding in the, the blood loss. Very good. Excessive menstrual bleeding, which affects the quality of life. Yes, very good. What is the normal amount of the, the monthly cyclic bleed? Hmm? On average, it is, let me tell you, on average, it is 35 mil. Okay. But if it is more than 75 to 80, okay, it will be converted into HMB. Again, HMB is subjective. Okay. HMB is subjective. So how are you going to, the measure? That is again subjective, right? To some women, I'm sure many women will come to you in your clinics, in your offices as well. They're saying, I am having very heavy bleeding. Okay. So when you will, of course, if it is heavy bleeding, it means a woman is losing blood. A woman is losing hemoglobin. So what will happen is that clinically women will be anemic. She will be exhibiting signs and symptoms of anemia, right? Plus, she will be having, the any clue which give us any clue, either clinically or laboratory, right, that she is having HMB. Or maybe, the when you see a woman who is, the apparently good, doesn't look anemic, okay, overall healthy, but she is telling you that I'm having HMB. So what will happen is that, of course, you have to go for some, the laboratory analysis as well, right? So basically, HMB is what? HMB is the excessive menstrual loss, which impacts the individual quality of life. While sanitary products are changed 1 to 2 hourly, or where menses last longer than 7 days, because it is a regular bleed, but with the longer duration. Earlier, we used to call it as menorrhagia. Okay, so menorrhagia has been replaced with the HMB. So it's a good idea that you always the say HMB rather than menorrhagia. Okay, so the most common gynecological reason for referral of adolescents to the secondary care, the prevalence in adolescents varies widely in population-based studies, which is 4.8 to 37%. Write it down, very important. Right? A heavy bleeding, which impacting the individual's quality of life. And when we talk about quality of life, it does not mean physical, material. Okay, it means mental health as well. Always remember. Okay, so quality of life will be, the encompassing physical as well as psychological as well as sexual health. All right. So a woman who needs sanitary products, the changing after every 1 to 2 hours, or if the periods are lasting for more than 7 days, because it will have physical, psychosexual, psychosocial consequences with higher rates of fatigue, decreased verbal learning, memory, depression, and school, the absenteeism, because we're talking about adolescents, right? So the usual adolescent menstrual cycle is, the average age of menarche in UK, 12 to 13 years. A typical adolescent period lasts between 2 to 7 days and occurs every 21 to 45 days. Yeah, normal cycle. So in the first few years following menarche, 50% of the cycles are going to be anovulatory, right? Because why? Because the HPO axis, hypothalamo pituitary ovarian axis, is immature. With the passage of time, that HPO axis will get mature and the patients will have the regular bleed. In that time, what do you need to do? Because we do see many patients, many, the young, the adults. And while, I do my clinics, I do see, the couple of young, the girls with their mothers. And the mothers are more anxious than the girls, right? And what do we need to do? What do we need to say in those circumstances? Just, we just need to give them good counseling, okay? Good support. Secondly, if a girl is having heavy periods, we will just give them symptomatic treatment. No hormones, always remember. Until and unless the girl is having, you can say that, the twice a month bleed or thrice a month, or if it is not, the stopping at all, then of course, then you have to introduce any hormone. But the initial, the 6 months to 1 year after menarche is going to be anovulatory. The girl can have, the irregularity in cycle. All right. It can be oligomenorrhea, the long cycle, that a girl can bleed after every like 2 to 3 months, or the girl may bleed twice or thrice in a month, or the bleeding might not stop at all. So in that scenario, you have to introduce something. All right. So counseling is going to be very imperative. Counseling of the mother. This is what I believe. Okay. Because if the girl is having HMB, so yeah, the girl will be having signs symptoms of, the same consequences like any adult, right? Anemia. The girl will not go to the school. The girl will be, the very shy, or maybe at times so the ashamed of going to the loo again and again, right? To change the pads or to change, the anything, right? So she will be having sign and symptoms of an anxiety, depression, or, you can say the social anxiety as well. All right. So in that scenario, yes. But again, counseling is going to be very imperative. So the first year of following menarche, 50% of the cycles are anovulatory, although by 2 to 3 years post-menarche, 75% of adolescents are going to ovulate regularly because HPO axis will get mature. So HMB commonly improves with time, and reassurance may all that some adolescents and their carers need. To our societies, I think these carers needs to be addressed quite nicely. Because what will happen is that if you will not talk to them properly, if you will not give them time, they will leave you, they will go to another doctor, or, or maybe here and there, the quacks. So what they will do is they will introduce hormones, and unnecessary hormones or unnecessary therapies are always dangerous. I am, the not always in the favor of introducing hormones to any woman there is whatsoever, until and unless, a woman is in the need of. Doesn't matter the age. So what you will do? Unable to see the slides? Let me check. No problem. Let me share again. Yeah. Is it okay, Iman? Is it okay now, Iman? Okay, Sadaf, very good. All right. So what you will do, you will have again clinical evaluation. You will have a complete menstrual history, right? You will ask about the associated symptoms. right? Age of menarche, cycle length, regularity, number of pads, tampon use, impact of bleeding symptoms, associated symptoms, dysmenorrhea, cyclical or non-cyclical pelvic pain, dyspareunia, dyschezia, very important. Bleeding from any orifice, very important, yeah? Bowel symptoms, weight gain, weight loss, hirsutism, epistaxis, bruising. Why do we need to ask them? Because a teenager might be having any underlying bleeding disorders, right? Sexual history, risk of pregnancy, STI, contraception, consent, past medical history, chronic illness, bleeding history, drug history, regular and over-the-counter medications, family history, bleeding disorders, PCOS, endometriosis, autoimmune conditions, hormone-sensitive cancers, social history, means a teenager or the adolescent is not going to the school. Concerns, rebullying, yeah, self-confidence, loss of confidence, effect of symptoms on relationships and friendships as well, even. Okay, so very important that we are talking to them very nicely, very politely. We are asking them everything. Okay, maintain a good rapport, and because you are talking to the teenager, isn't it? So it has to be a very good, the relationship, or you can say, the one-to-one counseling. All right. Then what you will do, girls should be encouraged to keep a diary of their menstrual cycles on either a phone app. I'm sure you all are aware of that these days we have got, the pretty nice menstrual app, okay, menstrual diaries app, or they may have a paper to aid the evaluation. A sexual history should always be taken in the absence of a caregiver, including details and the ages of the partners and assessment of any potential issues. Then you will do the examination. However, it is rarely needed. If it has to be performed, it has to be, first of all, in the presence of chaperone. Okay, you should not be doing any examination without any chaperone. That is not a good thing at all. And then you are going to assess them for complications from the bleeding or signs of an underlying cause as well. It may also be useful to reassure the girl at the start of the consultation if an examination will not be needed. You will tell them that, look, I'm not going to touch you. I'm not going to do any intimate examination. So don't be upset. Okay. So just talk to me. Whatever am I asking, talk to me freely. And if she needs to maintain the confidentiality, because we clinicians know if somebody is hiding something or if somebody is, the hesitant to talk in the presence of, the anyone. So we can maintain the confidentiality as well. We can ask them that, look, nobody is going to be, aware of whatever we will discuss here today, right? So the talk is going to be confidential. It is going to be strictly between us. And I'm not going to tell it to anyone until and unless you are going to, ask me to do so. So confidentiality is another part because we don't know whether she is active, sexually active or no. All right. So we need to maintain confidentiality. We need to make a very good rapport, and then only she will open up. If she will open up, she will answer your all questions, and this way you can, go to your potential diagnosis. Okay. So what it will do is altogether, it will reduce the appointment-based anxiety. Yeah. A chaperone must be present for any clinical examination, with the girl having the choice of a parent or any carer. So what do you do in terms of investigations? Generally, treatment can be initiated without additional investigation. However, NICE says that full blood count should be done, right? Full blood count, why? Because if it is true HMB, the woman is going to be anemic, isn't it? Because like I earlier said, if she is losing blood, it means that she is losing, the hemoglobin as well. So if she is losing hemoglobin, it means that yes, she is going to be anemic. So apart from that, the clinical judgment is equally important, right? The British Society of Pediatric and Adolescent Gynecology recommend the ferritin is checked alongside the full blood count and a coagulation screen, including fibrinogen, prothrombin, and activated, the APTT should also be done for adolescents. Okay, we are talking about adolescent. If any girl or a woman is having HMB since menarche, then there are chances that she is having underlying potential bleeding disorder. Okay, so then later on you will go for further investigation. So further investigation in whom you have started any medications and she's not responding to any medical therapy, or she's having any underlying pathological cause. Maybe she's having ovarian cyst, or maybe she's having any fibroid. Okay, so yes, you need to find out the cause as well. When suspicion of a bleeding disorder is high, this should include a von Willebrand disease. screen and testing for the factor 8 levels. A hormonal profile, a TSH level, because many at times we do see hypothyroidism. If hypothyroidism is there, then yes, the girl can have, this HMB. And an elevated prolactin more than 1,000 will warrant further investigation, because then we are expecting what? We are suspecting prolactinomas, maybe. Where PCOS is suspected, clinicians should measure their serum testosterone, SHBG, and you will calculate the free androgen index. STI screening, urine pregnancy test should be performed in a sexually acting adolescent presenting with the abnormal vaginal bleeding, with abdominal or pelvic pain, abnormal discharge, or cervical excitation. Right? Because if she is having any abdominal or pelvic pain, then yes, we should be, having potential diagnosis of ectopic, potential diagnosis of acute STI, isn't it? So that's why in this, whenever you will talk about any sensitive question, ensure confidentiality first, okay? Ultrasound may be useful if you are suspecting any pelvic mass or if you are suspecting any congenital uterine anomaly. A pelvic scan may show you the normal uterine development and normal for aged adolescent ovaries. So always, again, in terms of when you are going to, because in my opinion, it is useless to do any ultrasound scan in such teenager. Why? Because the uterine size is not going to be of adult size, right? I'm sure you all have done anatomy and you know that. Okay, so because the uterine size may vary, uterine development may vary in adolescent, and adolescent ovaries will, they vary. Okay, so sometimes it is going to be very much normal and it is going to be the reassuring for the both girl and the parents. However, I think personally 50% of the cases are going to be okay with your good counseling. Okay, so because we are talking about teenagers, so what you will do, you will perform a transabdominal scan. Transvaginal scan may give you a more comprehensive assessment. However, you're not going to offer them unless woman is sexually active. Again, there is another talk article that says even if the girl is sexually active, adolescent girl we are talking about, okay? So if she refuses to go for transvaginal scan, don't push her, okay? Don't push her because the autonomy is preferred in all cases. Okay, because we are in RCOG syllabus and they say even if they want to go for something which is not good for them, and we as a clinician know the outcome, we as a clinician know that this is not good for them, but yes, we have to respect the autonomy. Whatever they choose for themselves, that is okay. Our job is to give them all choices with all pros and cons. Okay, that's why consenting is equally important. All right, I hope I'm making sense. Yeah. All right, clear so far? So again, you will first of all establish the diagnosis. You will make a diagnosis and then you will go for the investigation and then you will go the management. Clear, everyone? Yeah. Okay, then you will establish the cause, right? Bleeding disorders, what we have said earlier, that bleeding disorders are going to be, there. You will be talking about, okay, family history. You are going to be going for von Willebrand disease. If it is von Willebrand, yeah, then yes, you have to offer factor 8 level. You have to offer von Willebrand factor level as well. Very good, Farheen. Very good, Amina. Very good. Okay, then type 1, the von Willebrand factor is very common. Type 2 may result from functional abnormality. Type 3 is the severe deficiency. Type 4 is going to be, the very, there is deficiency of the von Willebrand factor altogether. So what you will do in that case? If you are suspecting, you will refer to hematologist. Okay? You will refer to hematologist. Then ITP. Okay, write it down. ITP is 7%. Immune thrombocytopenia. Okay, so the diagnosis of ITP is typically made on the full blood count and peripheral blood film. Okay, stop. Why peripheral film? So this, perhaps it might be useful for you guys as well, because when we were in our residency program, so we used to write the full blood count with peripheral film. Okay, so peripheral film gives us the clue So this is still in my, this practice, now as well, that I always write complete full blood count with peripheral blood film. Because sometimes what does it do is that it will give you clue as well. Okay, cytology, peripheral film, very important. So you will have different, the shapes and forms of the thrombocytes. So what will happen is that, you will have a clue about the thrombocytopenia as well. Okay, so inherited factor 8, factor 9 deficiency as well. Although hemophilia is an excellent recessive disorder, the girls are going to be carrier, but they will show bleeding tendencies. Very rarely factor 2, 5, 7, 10, 13 may be considered if there is a positive family history. Okay, in what, the population, this Jewish Ashkenazi, the Jewish population. A clotting screen may guide further investigation with input from a clinical hematologist. Okay, so a very clinical tip to my all, the Pakistani candidates, who are here. So always expect, these bleeding deficiencies in ethnic population of, the descent from, the Balochistan, from, if you are in, the Karachi, so maybe from the Layari area, okay, towards the Habchoki area. So the patients who are coming from those areas, because, they do have, the tendency of development of these, and they do have family history of these, the ITPs and, the multiple inherited disorders as well. So do, the try to make a, the differential, always make a differential, okay? And apart from that, what I have read from my medicine knowledge as well, that, these, the African, the African descents, okay? So they do have, the underlying causes, some of them as well. So if any patient with such ethnic population, the coming to you with any, the history of this bleeding since menarche, so make sure that you are having this diagnosis in your mind as well. 1 millibrand, ITP, okay, or any other the rare factors as well. So what you will offer them? You will offer them the PT, APTT, bleeding time, clotting time. Okay, at least. So you will have, but first baseline. Okay, full blood count with peripheral film, and from peripheral film you will move onwards. If you see that a woman, if the girl is having any underlying thrombocytopenia, any underlying, the disorder you see, yeah, so then you will offer PT, APTT, you will offer bleeding time and clotting time. Okay, this is a clinical tip. Then you will be thinking of endocrinopathies, right? So first we have discussed hypothyroidism, polycystic ovarian syndrome, Ehlers-Danlos syndrome. So in Ehlers-Danlos syndrome, what will happen is that it is going to be a multifactorial pathophysiology. The patient will have platelet functional abnormalities, weakening, because Ehlers, the Danlos syndrome does what? It has, the problem with the collagen production. And collagen is a, the integral part of endothelium, isn't it? Basement membrane. So what will happen is that a patient will have altered platelet plug formation. Plus, if a girl is having underlying childhood SLE, so she will be having 50% of the cases of HMB because of the thrombocytopenia. Okay, lupus anticoagulant hypothrombonemia syndrome is a rare complication of SLE, but it is going to be there in cases of severe bleeding tendencies. Okay, so what endocrinopathies we are looking at? Hypothyroidism, polycystic ovarian syndrome, 8 to 11%. Yeah. EDS or Ehlers-Danlos syndrome, childhood SLE, 50% of the cases, and lupus anticoagulant hypoprothrombinemia. Then the other causes can be endometriosis, right? However, endometriosis might not present with HMB, as per se, because the HMB is what? Heavy menstrual bleeding, and endometriosis is what? What you can say, the triad of the severe dysmenorrhea, severe dyspareunia, coupled with subfertility, right? So what will happen is that it may be of having a variable manifestation in adolescent. It may be asymptomatic. It can have, the multiple causes. So although it's not a, the common problem, but yes, you can keep it into your differential. Then, Supraphysiological insulin-dependent diabetes mellitus type 1, because autoimmune tendency is also going to be there. If a woman is having, the epilepsy, just one moment, please. So some anti-epileptic drugs, such as sodium valproate, carbamazepine, oxycarbamazepine, lamotrigine, or the drugs which are used in the bipolar disorder, they may affect the androgen synthesis in the ovarian theca cells, and it will result in irregular bleeding. And any erratic bleeding can start from spotting to HMB. Any enzyme inducers, such as carbamazepine, phenytoin, phenobarb, rifampicin, high-dose topiramate, reduce the efficacy of CHC or oral progesterone, and it may lead to breakthrough bleeding and contraception failure. For individual taking any medication, such as the Mirena or DNPA injections, they may have some other problems as well. So any breakthrough bleeding, we can add the Mirena as well in those cases. Okay, so vascular liver diseases such as extrahepatic portal vein obstruction, Budd-Chiari syndrome, portosinusoidal vascular diseases are associated with clinical or biochemical hyperandrogenism, and 21% will experience HMB. Okay, so again, the theme is same. Establish the cause. Okay, first of all, diagnose the disease, establish the cause, and management according to the cause. Okay, so most adolescent can be managed in outpatient care. However, admissions to an acute gynecology or children unit for those under the age of 16 should be arranged if bleeding heavily, hemodynamically compromised, or significantly anemic, means hemoglobin is less than 8 gram. So they will primarily be managed by the multidisciplinary team approach by a gynecologist with a specialist interest in pediatric and adolescent gynecology, hematologist, endocrinologist, psychologist. See, psychologists you will see in almost all cases because of the potential rise in the mental health problems, right? But many a times HMB can be managed in the outpatient clinics. Okay, so outpatient appointments may be in person or it may be virtual, and it should be timed to minimize the schooling disruption. Consultation provide clinicians with an opportunity to educate girls about their menstrual and sexual health. HMB management should consider their physical, psychological, and social well-being. If they have any chaperone, well and well good. If not, you will ask your staff or you will ask your nurse to sit with you. Okay, very important. So how do we manage? Again, HMB will be managed on the lines of, the same. Hormonal treatment, non-hormonal treatment. Okay, so always divide. Non-hormonal treatment, tranexamic acid, mefenamic acid. Okay, so how are you going to prescribe them? 12 to 17 years of age, 1 gram 3 times a day, up to 4 days. Maximum you can give 4 gram in a day. All right. Mefenamic acid, you can give 500 milligram up to 4 times a day. Give them, counsel them that it's safe to be used. Yeah. However, they can have minor side effects, nausea, vomiting, diarrhea. We all are so used to of telling to all of our patients, isn't it? Nausea, vomiting, diarrhea is always going to be there. So very important that you rule out certain, the drug allergies to, the rule out contraindications. For example, for tranexamic acid, fibrinolytic conditions, convulsion, thromboembolic, the phenomena, VTE history, right? Acute GI bleed, ulceration. You are not going to prescribe your mefenamic acid as well. Combined hormonal preparation later on, non-hormonal, 2 medicine, then hormonal, combined hormonal, microgynon, 30. Okay, 30 means that you have to give them at least 30 means that the estrogen is 30 microgram. And then coupled with levonorgestrel 150 microgram daily for 21 days per cycle or continuous. All right. So the side effects can be unscheduled bleeding because you are giving hormones from outside. So there is almost always going to be chance of unscheduled bleeding, means breakthrough bleeding, spotting. Okay. The bleeding might not get settled, but it will get settled with the passage of time. So revise it from the talk, the contraindications, very important. So they are the general contraindications here, UKMF3, UKMF4. Okay. So 70 to 80% of the amenorrhea will be achieved if taken continuously. Then tranexamic acid we have done. Okay. NSAIDs we can give. Symptomatic iron deficiency anemia should be managed. Okay, very important. Better oral. If oral is not tolerated or compliance is the issue, then yes, the IV iron. Okay, 2 to 3 divided doses. Then if the another the hormone we have to give, there are the multiple the formulation like Marvelon, like Yasmin, like Loestrin, like these Culera, Cociprin, the Diol, Dianeti. Okay, so depends on the cause, depends on that what we need to give them. So Dianeti or the Dian 35, right? So it should not be considered as first line treatment in HMB. Always remember, okay? Because it has got high BT risk. Number two, it is not the the first line treatment for the HMB from FIGO and the NICE guidelines, both as well. Okay, so the first management option in HMB in adolescent is going to be the non-hormonal preparation, tranexamic acid, non-steroidal anti-inflammatory drugs. If that's not working, then we may put them on, the COCP, combined hormonal contraceptives with low estrogen, 20, the microgram. All right. And then we can ask them to continue that. Okay. 22, sorry, not 20, 30. All right. So that is important. So it will mimic the natural, the menstrual cycle. Then, the progesterone only preparations. And this is also from, the combined, the estrogen or combined hormonal, transdermal patch, vaginal ring. But yes, we are going to avoid if she's not sexually active. Progesterone, on the other hand, norethistron acetate, we will give 5 milligram 3 times a day for 21 days to arrest the bleeding. And then 5 milligram 3 times a day from 5 to 26 days cycle, but for short term. Okay. Me myself, I don't, they prefer this norethistron on the long-term use, but I have seen, the clinicians prescribing this norethistron as a, the chocolate or toffee. So I would suggest that avoid it because it is not a good thing to go for, the long-term control of the bleeding. So caution with the prolonged use in people with the COCP if it is contraindication, as norethistron acetate is metabolized to ethinyl estradiol, long-term use will be associated with hepatic adenomas. So be extremely careful when you choose any hormone for your patients. Okay. However, to arrest the acute bleeding, we may give norethistron, but not for the long-term use. All right. Clear so far? Any question? I hope I'm bringing sense because I'm making the scenarios as well clinical, so it will give us a good the idea, right? Very good. Adila, Aisha, Iman, Manikam, Farheen, Saira. Clear everyone, everything? Yeah? Rabia?
Yes, ma'am.
Okay, okay. At least say yes or no. So yeah, it will be good for me as well that we are on the same page. All right. So CHC we have just spoken about. Okay. So it is the first line therapy. However, you need to look for contraindications. Okay. You can make 3, you can make 4. So of course you are going to be very careful. Again, education is very important. Counseling is very important. Plus, the compliance. Compliance is very important. Okay. So progesterone only preparations may be considered for adolescents with HMB seeking long acting reversible contraception, or those with contraindication to CHC. So what is going to be our, the LARC in this scenario? LARC in this scenario is going to be desogestrel, 75 microgram once daily, is the first line progestogen only pill for adolescent with HMB. Okay, this is relatively new now. Okay, so make sure that you keep a concept. Amenorrhea is often desired by the patients, which is only achieved by half to 1/3 of the patients after 9 to 12 months. An unlicensed double dose 150 microgram may increase amenorrhea rates and could be trialed after 3 months if required or desired. Okay, so we do have one, the option. Then we do have the second option, northestrone 5 milligram 3 times a day or medroxyprogesterone acetate 5 to 10 milligram twice a day. It can be used cyclically to promote a monthly withdrawal bleed. And it should be started on the day 5 of the menstrual cycle and continued until day 6. Okay, this is also another good clinical tip. Start from day 5 and take it up to 26 days. It means we are using it for total 21 days. Yeah, good. Then using progestogen, for example, MPA 10 milligram daily for 12 days every 3 to 4 months will induce a withdrawal bleed and protect against endometrial hypoplasia and HMB associated with prolonged anovulatory cycles. Norethistron 5 milligram TDS is associated with increased risk of VTE. Okay, so avoid in the long-term use. I think this is a good exam scenario. Norethistron is associated with androgenic side effects as well. Where the CHC is contraindicated owing to VTE risk, medroxyprogesterone is good. Medroxyprogesterone is preferred to norethistron. Okay, so let's conclude this slide. Number 1, if a patient has had history of, the VTE, don't choose norethistron. Okay, choose medroxyprogesterone. If you have to choose this progestogen for the long period of time, choose medroxyprogesterone or choose LARC. From the LARC, you have to choose desogestrel. Okay, and even Mirena as well, if she is, the active. All right. Then Mirena is going to reduce the excessive menstrual loss. Okay, then anything there is. It may cause irregular bleeding in initial 6 months, but 65% will have amenorrhea or reduced blood loss by 12 months. They have higher quality of life later on, The bleeding will stop, the dysmenorrhea will be good, plus, the patient will be having additional, the benefit of contraception. So it's a good deal, isn't it, altogether? So LNG-IUS, because it works locally, so it can be, given in the bleeding disorders, any connective tissue disorders, because it has got high acceptability rate. Cardiologist involvement should be sought in girls with increased risk of arrhythmias. Antibiotics are not routinely required to protect against infective endocarditis. So it can be fitted in the gynecology outpatients. However, specific groups need, the specific attention. All right. Then DMPA is an appropriate alternative when the CHC are contraindicated, medroxyprogesterone acetate, okay, depot injection. So if they have, any compliance issue or if the treatment has been failed, so in that scenario, we may offer them injections. So injections will have irregular bleeding initially. And however, 60% of the users are amenorrheic at 12 months and 70% will be amenorrheic by 24 months. But if we are using them for more than 5 years, there is going to be association with irreversible osteopenia. And it is associated with high rate of weight gain as well. Okay, so the risk and benefits should be considered and it requires a regular review. Now, the new injection, Cyanopress, it's also, the medroxyprogesterone acetate, the injection. It's a subcutaneous depot injection, which can be self-administered as well. Later on, etonogestrel releasing implant can also be there. Okay, but it is not licensed under 18 years of age. So it cannot be used for the treatment of HMB. So to conclude, HMB, progestogen, our choices. The choices are norethistron, medroxyprogesterone. We do have DMPA. We do have Mirena, right? We do have Cyanopress. But etonogestrel is not licensed for less than 18 years of age group. Okay, again, the every choice will depend on patient's safety profile as well. Okay, the compliance, the side effect profile. So you have to, the offer all options, and then you have to tell her that which one is going to be suitable according to her condition. So all these things are going to be there, right? So this is again, a good summary of this HMB. How are you going to, do? So let's quickly summarize. Okay. So evidence of hemodynamic compromise. For example, this is for the acute, the bleeding. Okay. So if acute compromise is there, for example, tachycardia, hypovolemia, which will lead to decreased blood pressure, the parameters as well. So we will follow this pathway. If there is no hemodynamic compromise, we will follow this pathway. Okay, so acute bleeding, we will, give two wide bore cannula. We will send full blood count, urea, electrolytes, the clotting screen, venous blood gases, urinary pregnancy test, crystalloid fluid resuscitation, the acute management of hypovolemia. Side by side, we will evaluate clinical history, clinical examination, plus alert child safeguarding team, police if sexual assault is there, right? Look for any non-accidental genital trauma. If it is acute anemia, hemoglobin is less than 8, or active bleeding with hemodynamic compromise, despite fluid resuscitation, yes or no? If yes, we will offer them, the group or the pack cell, O negative, the 2 units. Platelet transfusion if platelets less than 50,000. Clotting factors if severe deficiency. We may give tranexamic acid to control acute loss. We may give medroxyprogesterone acetate, 10 to 20 milligram orally up to 8 hourly until bleeding is restored. Okay. Ultrasound or plus minus EUA. Okay. Balloon tamponade using Foley catheter if underlying bleeding disorder or hemodynamic compromise not responding to hormonal therapy. However, if there is no acute hemodynamic compromise, you will do the same pathway: clinical history, examination, UPT, full blood count, clotting screen, consider transabdominal pelvic scan, additional investigation. Give them tranexamic acid 500 to 1000 milligram orally 3 times a day for up to 4 days if no contraindications. Iron infusion for anemia without hemodynamic compromise, oral iron replacement for mild anemia. You may put her on hormonal treatment with medroxyprogesterone oral tablets, yeah, for 21 days. Consider long-term need for the contraception and HMB management. You may discharge the planning, treatment plan, outpatient follow-up, and contact details. Plus, give the contact details of in terms of emergency, whom to contact, where to come. Clear, everyone, this part? This is a very beautiful chart indeed. Clear, everyone?
Yes, ma'am.
Good. Good job. Okay, so we have the managed acute bleeding. We have managed the long case as well. Now we will talk about the special circumstance, isn't it? We do see special circumstances, learning disabilities patients, for example, Down syndrome, for example, Turner syndrome, for example, the autistic, the girls as well. So what are you going to do in those scenarios with HMB? Yeah, you are going to the manage accordingly. What are you going to do? They girls with the learning disabilities may find monthly bleeds distressing, yes, problematic, yes. So what you will do, you will offer them continuous or long-acting preparations with high amenorrhea rate. Okay, so continuous extended use of CHC is popular choice to reduce the menstrual severity, pain, and allow scheduling of the withdrawal bleeds. Okay, so what you will do in this scenario, you will consider, the comorbidities. You will consider drug interactions, anti-epileptics, first of all. What if she is, epileptic and she's on anti-epileptic? So very important. So transdermal CHC are an option when there is difficulty taking oral tabs. DMPA has a high amenorrhea rate and is suitable for girls in whom CHC is contraindicated. Always remember, again, the first choice is CHC, right? Number 1. If it is contraindicated, you may go for transdermal, you may go for DMPA, you may go for the LNGIUS. Again, in learning disability girls, for LNGIUS, they might not allow you to do the fitting of LNGIUS in OPD setting. They needs to be placed in the general anesthesia. Girls with learning disability will usually be accompanied by a parent or a carer. However, the consultation should be directed with the girl as much as possible. Talk to her, okay? Information should be derived multimodally using verbal, visual, and written information. Hospital learning disability team should be there. Independent patient advocates should be there. Okay. So if it is, this is the again same, okay, management of the acute heavy menstrual bleeding. So these learning disability, the girls, if they are having, the heavy bleeding, they should remain inpatient until the bleeding has stabilized. We recommend performing a pelvic scan or screening for underlying bleeding disorders, given their high prevalence in the hospitalized population. Okay. On discharge, a robust follow-up plan should be given. Medication planning, contact details, clinical nurse specialist, online resources, follow-up review in a pediatric and adolescent gynecology unit if available. Hormonal therapy is first-line treatment in the management of acute HMB and various options are available. Both CHC and oral progesterone are effective. However, common UK practice is oral progesterone as first line in the setting of restoration of stopping of bleeding. Okay. So then they have concluded some data. Okay. A single retrospective data comparing medroxyprogesterone 20 milligram 3 times a day versus 1 milligram norethindrone. TDS found that bleeding had ceased in 88% of CHC group and 76% in the progestogen group within 3 days. We are talking about acute arrest of bleeding. Okay. Norethindrone is a safe alternative to medroxyprogesterone. Tranexamic acid can be given 1 gram orally or IV, in the acute setting. All right. Surgical therapy for acute HMB is rarely indicated, like UAE, like the until and unless there is any pathological cause. Okay. If it is because of the fibroid, if it is because of the ovarian cyst, so in that scenario, maybe yes, but otherwise, no surgical. So what you will do, for example, if a girl is coming with the heavy bleeding and you may the suspect that she may be having underlying bleeding disorder, so in that scenario you may give the compression with the Foley's catheter. Okay, you will the uh, inflate the balloon. Okay, so what it will do is that it will compress the this myoendometrial junction and the bleeding may be less. So this is how you manage HMB in the adolescent. Okay, if there is any question, any query, please do ask. Any question, guys? Thank you so much, Saira. Thank you so much. Thank you so much, Amna. Rabia, thank you. I hope everything is clear to all of you. So we have discussed two potential exam, the talk articles, and which are having equal relevance with our clinical practice as well. If you guys have any question, any query, do write to me. Or any query regarding, the exam or anything. Or if you face any difficulty in exam, okay? So we are open for registrations, okay? We are open for part 2 MRCPI as well as part 3 registrations. Anybody who is interested to study with me, okay? So you guys are encouraged, you guys are invited to join me, all right? So inshallah, we will have, the all study sessions, very interesting with regard to, the exam as well as our clinical practice as well. So I believe there is no question. So no problem. Aisha, any question? Yeah.
No, ma'am. Jazakallah.
Okay. Thank you. Thank you so much. Thank you so much. Thank you so much, guys, for being a wonderful audience, for very attentive. So I have literally enjoyed the session today because it was very clinical. So you guys can suggest to me if you guys want any other session in upcoming days. So I will try to summarize. I will try to to bring, because this way we can communicate well, and this way we can discuss and we can study in a good way. So before I conclude, if you guys have any suggestion, anything, okay, do write to me for any the exam related query, any, for the booking process or any, the exam, any query. So do tag me. Okay, do tag me. And if I miss any tag, no problem, do tag me again. All right. So thank you so much. The recording will be available. Yes, recording will be available. Okay, once it is processed, it will be uploaded and you guys will be notified by the team. So if you guys have any query, any suggestion, anything, do write to me. All right. Thank you so much. Thank you so much. I will arrange another session in like, maybe, yeah, 2 weeks time. So we will gather and we will discuss again. All right. Thank you so much. Okay, bye bye. Take care, everyone. Allah Hafiz.